Yeah.
Good evening, everyone. I, Dr. Alish Mehta from Sion Hospital, and my colleague Evangeline from ICH Chennai hereby welcome you all for this new lecture on neuroblastoma organized by the IAPS. For presenting this, we have an honored member of IAPS who is an extraordinary teacher, Dr. Sushmita Bhatnagar ma'am. She's a consultant pediatric surgeon at Bombay Hospital, Global Hospital, Apollo Hospitals, etc. She was an immediate past president of APSO IAPS, which is a sub-specialty of IAPS dealing with pediatric surgical oncology. She has held many positions such as president, treasurer, website editors in many other associations, not only of pediatric surgeries, but also other domains like Association of Medical Consultant, Association of Medical Women in India. She has won many national and international awards and has been author of more than 100 publications, both books and journals. She has been a postgraduate teacher, an examiner, a thesis supervisor, and whatnot. I don't think we would have any other faculty other than her to teach us the topic of neuroblastoma from basics to advanced. Hereby, we welcome you, ma'am, to please teach us the topic, and thank you, ma'am, for accepting this at a very short notice.
Thank you so much, Alish. That was a very elaborate introduction.
Thank you, ma'am.
So let me start off with two questions. Have you ever wondered why some tumors or some abdominal masses in children behave very unpredictably? You feel that they will do well and still they don't do well. The outcome is not as good.
Recording in progress.
Yeah. Just wait before you answer. And what we'll do is we will start the chat box, meaning answers can be in the chat box rather than verbally, people speaking up, because that will become an interruption in the flow of the entire session. And whenever we are speaking up, that will be the Q&A session in the end. Am I right? If there is any Q&A session, because it is possible that you don't have anything to ask, right? So my second question is, would you like to feel confident about diagnosing and managing one of the most common but also very challenging pediatric solid tumors? If the answer to both your questions is yes, then be attentive. Take down the points where you need more clarification, because it is possible that certain items, certain parts of the session would need more detailing. And keep the questions to your end, write it down, and then you can ask. In between the session, I might ask a few questions because I want this session to be interactive. And what you could do is, as I said already earlier, that you could type in the chat box. You could respond by typing in the chat box. And why these questions? It is not an exam. You're not going to be graded. I'm not going to be questioning you. Oh, you have not answered. This is to trigger your thinking. That is the main purpose. Because when you think more, you learn more. Agreed?
Yes,
So can we mute everyone else except me, please? So before I begin, I want to acknowledge each one of you for being here today, because y'all are the future pediatric surgeons and your role goes beyond the operating table. Am I audible? Yeah, okay.
Yes, ma'am.
Y'all are healers, decision makers, and often you have to deal with frightened families. So taking the time to deeply understand this tumor, neuroblastoma, it shows your dedication to that responsibility which you are taking up as a pediatric surgeon. So here's what we'll do today. 1 second, I'll just share my screen. Yeah, my screen visible?
Yes, ma'am.
Okay. Right. So, neuroblastoma, as you know, is the most common extracranial solid tumor in children. If we talk of incidence, then it is about 7 to 10% of all pediatric malignancies. And it has a very high mortality. So, 15% of cancer related deaths occur in children because of neuroblastoma. In India, the exact incidence remains a little challenging because there is underreporting, there is lack of centralized cancer registries, but there is in POG NB 1801 registry body in India, which is started by pediatric oncology centers across the country. So neuroblastoma is like a chameleon in pediatric surgical oncology. You like chameleons? Have you seen one? I have seen one, absolutely green color. But it is, when we compare this to neuroblastoma, what I am indicating is the tumor is very unpredictable, but at the same time, very fascinating. In some infants, it can vanish on its own like magic, while in others, it turns into an aggressive, fast spreading disease that challenges even the most experienced surgeon. So, today we are going to cover these 11 or 12 points. That is etiology, patho. You must have already read it by now. Complications of treatment I had already covered in one of the sections for APSO lectures, but I'll run through this today because it is all interrelated and correlated. Right, so let us look at the etiology. The prenatal and postnatal factors which I have mentioned about are the environmental factors. So there are three aspects to the etiology of neuroblastoma. Environmental factors, which are less, it is a small fraction, about 2 to 5%. The familial or the hereditary factors, which are again small, that is about 1 to 2%. And the sporadic cases, which is the majority. About 90 to 95% of cases of neuroblastoma are sporadic. They occur without any known inherited genetic mutation, and they result from some random somatic mutation during early development or during that embryogenesis. So let us just look at, though they are not proven, but we should be aware that these factors have been studied with not very clear cut indications whether these are definitive factors which cause neuroblastoma, like codeine, oral contraceptives, diuretics, antihypertensives, which the mother may consume, hair coloring agents, which the mother may be applying, parental occupational exposure to electromagnetic fields, hydrocarbons, and maternal reproductive history and pregnancy complications. Also, some associated congenital anomalies. So, when we talk of the hereditary factors, germline mutations, the ALK mutations, are linked to familial neuroblastoma. And there is an increased risk with Turner syndrome, Hirschsprung's disease, CCHS, which is congenital central hypoventilation syndrome. And which is this CCHS is associated with FOX2B gene mutation. And that is how there is an increased incidence of neuroblastoma in these patients. And in neurofibromatosis 1, where there is a mutation in NF1 gene, and this NF1 gene is a tumor suppressor gene for neuroblastoma. Okay, so let us look at the pathophysiology. There are these two important anatomical and physiological aspects that you must understand before we talk about in detail the pathophysiology, the histology, and all the other originating. These two things are the sympathetic ganglia and the neuroblast. Sympathetic ganglia is from the cervical region till the sacral region, and there are multiple ganglia, right? The G written over here is internal carotid superior cervical. G is the ganglion, the stellate ganglion, the splanchnic, celiac, superior mesenteric, interrenal, inferior mesenteric, hypogastric, and pelvic. And adrenal, of course. So when there is an abnormality of any of these ganglia, in the sympathetic nervous system, which includes adrenal medulla, as I said. Dr. Shweta, can you please mute yourself?
We have muted her, ma'am. Continue.
Okay. So tumors can occur anywhere along this sympathetic ganglia. The another thing that you need to remember is neuroblast. What is a neuroblast? It is a precursor cell of a neuron. Neuroblast differentiates to form a mature neuron. So when there is when the primitive neuroblasts of the neural crest deviate from their normal development, it leads to variety of tumors of neuroblastic origin, which may lead from benign to malignant. And some of these proliferative tissues can even regress over time, but some others can turn into malignancy, and the degree of malignancy could be variable in these two. So when we talk of the detailed pathophysiology of neuroblastoma, molecular research plays a huge role. So molecular research in which the role of oncogenes in these neuroblastic tumors have been studied. So they have not found a single one gene which has been accountable for all the tumors. There have been variations. These oncogenes implicated in formation of these tumors are MYCN, MYCN, which you already know, or NMYC, or whatever you may call it. The ALK, that is the anaplastic lymphose kinase gene. FOX2B is paired like homeobox2B, which affects the maturation of the neural crest in different stages, and thus it leads to different types of neuroblastic tumors. So all cases of familial and syndromic neuroblastoma show chromosomal mutations. But in sporadic cases, you will see that only in 6 to 10% of cases. So there have been extensive research, but despite extensive research, the common neuroblastoma specific chromosomal aberrations such as mutations, deletions, or translocations have not been identified yet. It is different for different tumors. So let's now look at what is the histology, because this also forms, understanding histology is one of the basic parameters to understanding this tumor. You all agree, right, that pathologists play a crucial role in the diagnosis and treatment of all solid tumors, but specifically the peripheral neuroblastic tumors. That is the neuroblastoma, ganglioneuroma, and the ganglioneuroblastoma. So in 1910, do you know who devised or who actually diagnosed this for the first time? You've heard of Shimada, right? But it was not Shimada. It was pathologist James Homer Wright from America. So he helped classify neuroblastoma as a primitive neuroectodermal tumor by Homer Wright body rosettes. I'm sure you know about this. This is classical pathological sign for a neuroblastoma. And this work still forms the basis of modern diagnostic criteria. Much later in 1984, Shimada introduced the pathologic classification based on this primary histology. So what is the primary histology of a neuroblastoma? So, you know, it's a small, round, blue cell tumor, right? So typical neuroblastoma, it is composed of small uniform cells containing dense hyperchromatic nuclei and scant cytoplasm. The presence of neuritic processes, that is the neuropil, is classical. Homer writes pseudorosettes, that is the neuroblasts surrounding areas of eosinophilic neuropil, are seen in about 15 to 50% of cases. So you see these processes arising from the small round blue cells. You can see my arrow, right? So these are the neuritic processes and they are called as neuropil. Ganglioneuromas basically have mature ganglion cells, the neuropil and the Schwann cells. And ganglioneuroblastomas have a picture, a mixed of neuroblastoma as well as ganglioneuroma. Because tumor histology plays a major role in both diagnosis and risk stratification of neuroblastoma, this evaluation, the histopathological evaluation, helps differentiate neuroblastoma from other round cell tumors. So here, what we need to look at, or what are the features in histopathology? One is cellular differentiation. Second is the Schwannian stroma. Third is the type of the tumor. Fourth is the nucleus of the neuroblastic cell, which gives us the indication of mitosis karyoresis index, that is MKI. And the fifth is the tumor cell ploidy. When there is cellular differentiation, good cellular differentiation, which means maturation of tumor cells, then it is a favorable histology. When the Schwannian stroma is rich, it is again goes in favor of, it goes with favorable histology. The cystic variety of neuroblastomas are favorable, and obviously the dense and hard would be unfavorable. I will be providing a little more detail on the MKI, but just to understand, a low and intermediate MKI would be favorable histology, and a high MKI would be unfavorable. If the tumor cell is diploid, it is favorable, but if it is multiplying much more, triploidy or hyperdiploidy, it is an unfavorable histology. So I mentioned about cell differentiation. So cell differentiation is categorized in three: undifferentiated, poorly differentiated, and differentiating. And what is undifferentiated? Maybe we don't need to go into detail of this. Poorly differentiated, where less than 5% of the tumor cells are neuroblasts. So look at this picture. There are two categories. One is the grade of differentiation, as I mentioned, and one is the stromal development. I'll ask you one question. Type your answer in the chat box. And Anish and Evangelina, am I right? They will check who has answered it correctly. First question is, of the above three grades of differentiation, which one is the best for treatment and prognosis? Undifferentiated, poorly differentiated, or differentiating? So you can write U, P, or D.
I think everyone has put D, ma'am.
Oh, great, fantastic. So second question, would you like to be rich or poor? Oh, I mean to say, would you like the stroma to be rich or poor? Type R or P.
Yeah, everyone has put rich, ma'am.
Wow, great, fantastic. That means you have understood what I was trying to make you understand. Fantastic. So the histological grading of neuroblastoma is based on these two key components. Now, when you go back, when you have a patient, look at the histopathology. Read the histopathology report in detail, what the pathologist has given. And if they have not written about these two things, please go back to them and tell them to give you the clarification. All right. So there are advanced diagnostic modalities. I am just covering it up. You don't need to go into the details, but you need to know that only histopathology is not enough for neuroblastoma diagnosis and risk grouping. There is IHC, that is the immunohistochemistry, FISH or PCR for MIC and amplification, which is done in most of the centers. CGH, that is comparative genomic hybridization. SNP is single nucleotide polymorphism. These arrays are done abroad. The ALK mutation analysis, we have already mentioned about ALK mutation, and RT-PCR for minimal residual disease, and the NextGen sequencing for genomic profiling, and it is for personalized treatment protocols. So the molecular markers also, when we are studying in detail, when we are doing molecular markers, again we have to categorize the tumor into favorable and unfavorable. So unfavorable ones are the one wherein the MICAN is amplified, wherein the segmental chromosome and anomalies of such as gain of 17q, loss of 1p and loss of 11q are identified, and gene mutations like ALK, FOX2B mutations are identified. And there are some lengthening mechanisms in telomerase pathways which have been picked up. Right, so that was in short the pathology or histology, the absolute basics. Now imagine a patient in front of you, and we are looking at the clinical features only. So there are four categories of clinical features. Aarti, can you please move? Right.
She's
So
muted.
why I have categorized it is because so that you don't miss out any of these. And I'm sure you know that neuroblastoma can present completely asymptomatic, which means picked up on some random investigation. It can present in countless ways. It can present of only one symptom of any of these four categories. And still you need to pick it up and diagnose neuroblastoma, right? So, primary site tumor, now I have mentioned over here, it could be with or without extension, because sometimes extension we are not really able to differentiate from, meaning there are no separate signs and symptoms of tumor with extension. So, general signs and symptoms of any tumor are these: anorexia, weight loss, lethargy, weakness, either because of the rapidly enlarging tumor or because of anemia or both. They could have fever, they could have sweating, palpitations. Hypertension could be one of the features in neuroblastoma. And when we talk of specific tumor site signs and symptoms, then it depends on where exactly the tumor is, whether it is in the head and neck, mediastinum, abdomen, or pelvis. So if it is in the head or neck, they may present with just a mass, or if it is extending, then it is Horner syndrome. Horner syndrome is ptosis. Why does Horner syndrome occur? It is because of damage to the sympathetic trunk. It results in ptosis, meiosis, anhidrosis, and in extreme cases, it results in anophthalmos, which means the size of the eyeball becomes much smaller. And the third one is heterochromia iridis, which occurs in even cervical and mediastinal, both neuroblastomas, where this occurs if there is any prenatal or immediate postnatal interruption of the sympathetic tracts, which mediate the pigmentation of the iris. In mediastinum, there could be mediastinal signs and symptoms could be cough, chest pain, tachypnea, recurrent respiratory tract infections, difficulty in swallowing as well, depending on the location of the tumor, respiratory distress, and decreased air entry on examination. Those in the abdomen could be lump, abdominal distension due to lump, and other features like ascites. There could be vomiting due to compression of some part of the GIT, specifically the duodenum. There could be constipation if the tumor is in the pelvis and the sacrum. If there is a pelvic tumor, then there could be a lump. Usually pelvic tumors, unless they are really large, do not present with a lump. They present with other symptoms like pain, constipation, difficulty in micturition, or other urinary symptoms, and sometimes even fecal incontinence. If there is extension, then you need to remember where the extension could be. Extension just into the local tissues is definitely there, but extension into other tissues like spinal cord. So patient can present like with just weakness of the lower limb, or he could just present with limb or a paraparesis. Limb can gradually progress to paraparesis or paraplegia, and then it could be a bladder or bowel incontinence because of the nerve roots. There could be extension into the lymph nodes. With these enlarged lymph nodes could cause compression of the adjacent organs, compression of the vascular structures, and compression of neural structures. Depending on the location, the sign symptoms will be different. But do remember that lymph nodes which are enlarged can cause symptoms, even if the tumor has not caused symptoms. And there could be encasement of the vessels, nerves, or the adjacent organs. So I'm sure you understand the extension to different the parts or different organs, and there is encasement of these structures. Now, paraneoplastic syndromes have a whole different ball game altogether, and a whole different set of features, clinical features. There could be hypertension, sweating, flushing, headache, and palpitations due to excess of catecholamines. Due to excess of or excretion of VIP from the tumor, there could be watery diarrhea, or there could be opsoclonus myoclonus. See, if opsoclonus myoclonus is very classical of neuroblastoma, which is immune mediated, and you can diagnose much quicker. The diagnosis of neuroblastoma can be much faster. But if it is just watery diarrhea, if it is headache, it really becomes difficult. But you need to keep it in mind that these symptoms and signs could be signs and symptoms of neuroblastoma. So metastasis. Now there could be metastasis to the head and neck, meaning abdominal tumor can give rise to metastasis in any of the areas, or a head and neck tumor can give rise to metastasis to abdomen or chest. So metastasis could be anywhere. If there is a metastasis to the head and neck, proptosis and periorbital ecchymosis, that is the raccoon, it occurs because of retrobulbar metastasis. And headache, convulsions, vomiting, altered sensorium occurs due to intracranial metastasis. Horner syndrome, we have already covered. There could be musculoskeletal, that is the skull metastasis can lead to scalp nodules, bone pain due to bone marrow or bone metastasis, and the patient can present with trivial trauma. Fracture due to trivial trauma, and weakness and pallor due to bone marrow infiltration. Subcutaneous skin nodules due to metastasis in stage 4S to the skin is a very well-known feature. So as I said, abdominal metastasis could be intra-abdominal to lymph nodes, to liver. It can cause ascites, which can cause severe abdominal distension. It could be to the lungs, causing cough, chest pain. So cough, chest pain could be due to features of a primary as well as due to features of a secondary. Tachypnea, respiratory distress, same thing. And If it is metastasis to the nerves, then they could be paraplegia or bladder bowel incontinence. Delayed presentation, I have had pictures, all of them are not mine. I have picked up from few other presentations as well. Some of them are mine. You can see this nodule here, this scalp nodule here, this in the X-ray. This is retrobulbar metastasis. This is again scalp nodule. So I would like to say that majority of the patients of neuroblastoma have advanced disease. Do you know why that is? And we need to accept that, because what happens is when a neuroblastoma patient comes, we focus mainly on the primary tumor. We don't focus too much on metastasis, which is unlike Wim's tumor. So here we need to accept that there could be a metastasis, and I am going to be telling you that you need to look at the clinical parameters. You need to look at the tumor growth, which means in the history as to when did the symptoms begin. And even when there are no symptoms or when the tumor is small, metastasis can occur. And they can remain undetected till advanced stages. So that is why understanding this aspect that advanced disease can be there at presentation is an extremely important parameter, or which we need to keep it in mind always. This study, which was done by INPOC, they clearly mention that majority had metastasis at the time of presentation, and most of them, so many of them, 24 out of 90 patients had unresectable disease. So if we talk a percentage, metastatic disease was 52% in these patients in this study. So now clinical features, I'm sure you can easily write if you have any
Why
question
are
in the
you
exam.
telling like that?
Sorry, was that directed to me?
No, ma'am, I think accidental. We have muted them now.
So let's look at the diagnosis. How do you diagnose neuroblastoma? Some tumors do not have any tumor markers, but neuroblastoma has many tumor markers which you can utilize for your benefit. Imaging studies, obviously in all tumors we do imaging studies. Radionuclide studies specific for neuroblastoma, which I will be covering, and histology, immunohistochemistry, as well as molecular markers. All of these are important. All of these are not just important, are required for diagnosis, for correct diagnosis. And is diagnosis only important? Sometimes we can make a diagnosis only by palpating. I have done that. Just palpate the tumor, said, no, this is not Wim's tumor, this is neuroblastoma. In your exams also, they will ask you, what are the features which go in favor of neuroblastoma? You need to give a differential diagnosis for abdominal tumor palpation, right? So when you give a DD, you will say first neuroblastoma. So why neuroblastoma? You can diagnose, but is that enough? Obviously not, right? And there is another important aspect of investigations, of thorough investigations in neuroblastoma. You remember the screen that I shared about the histology, the histopathology, right? So grading of the tumor, and also the risk grouping. We have not covered that yet, but risk grouping is an extremely important aspect in appropriate management of neuroblastoma. So blood investigations, I am talking of only the ones which are diagnostic, not the routine investigations. Routine blood investigations are to be done in all patients. but LDH. Now, LDH is high in all patients of tumors, right? It is high even in leukemia. Why LDH is mentioned in neuroblastoma specifically? Because you can monitor the response to treatment by the LDH levels. If the LDH levels are falling, then we would. Okay, I just realized that we are already 45 minutes past in this session, and we have a lot to cover. Is it okay if we extend beyond 1 hour?
Yes, ma'am.
Are you all willing to wait? You all can bring your plates. If you want a break, if you can get your food, then you all can get the food. But let us finish this. Otherwise, we'll have to do it in 2 sessions. And if we do it in 2 sessions, by the time we do the second one, the first part may have been forgotten.
Ma'am, we'll continue, ma'am. There is no bounding to the time. At least we'll have an important topic covered.
Right. So now the first thing I mentioned about is LDH. The second is ferritin. Now, ferritin is a marker of advanced disease in neuroblastoma, and persistently high ferritin levels have been found to have poor prognosis. And that is why ferritin comes into the investigative list of neuroblastoma. Then there are catecholamines. There are serum catecholamines as well as urinary catecholamines. The serum catecholamines are VMA, MHPG, that is 3-methoxy-4-hydroxyphenyl glycol, then HVA, which you know about. And these have been found to be 15 to 30 times higher than normal in our children with neuroblastoma. It is a little cumbersome. Serum is not as cumbersome as urinary, but urinary is a little cumbersome to because you have to prepare the patient for 3 days and then take it in a proper container and then send it to a center where these tests are being done. So all these things are there, but it is an important tumor marker. Wherein much high elevated levels are not just for diagnosis but also for monitoring the treatment. There are
Alish, can you hear me?
Yes, yes, I'll just call, ma'am. I think she has logged out accidentally.
Yeah.
Ma'am, we can start. Thank you.
Yes. Thank you so much, and I'm really sorry. We were talking about the urinary biomarkers, 3-MTS, CTN, and COR. These are the one core is cortisol. We will be coming to all of these a little later also. So these are elevated in neuroblastoma, but core is elevated only in the cortisol is elevated only in adrenal neuroblastoma. So only if we have diagnosed with imaging studies, then only there is a purpose of doing COR. Imaging studies, you know that very well. I don't even need to cover what all imaging. Plain X-ray nowadays people don't do it. But I suggest that we should always do a plain X-ray abdomen. If there is an abdominal tumor, plain X-ray chest. If there is a chest tumor, you see a lot of other characteristics, features when we do a plain X-ray. Ultrasound with Doppler is a must for the blood flow, blood supply, and the encasement, the narrowing of the vessels. CT scan with the contrast, of course. MRI. Yeah, I prefer MRI over CT scan for any solid tissue. When we talk of X-rays, for the chest, X-ray is one of the best investigations. You know the exact size of the tumors. Meaning, I'm not saying you are not going to do a HRCT, or you're not going to do MRI. I'm not saying that. I'm talking about the information that you get on an X-ray when there is a thoracic and a cervical tumor is definitely worth noting down. Okay, so yeah, I was showing you these X-rays which have been taken. This first picture is metastasis. This is a large tumor with, the extension into the lymph nodes. This is the tumor with lot of calcification. Here, the second picture shows metastasis into the pod. And this is extension. The third one shows intraspinal extension. Radionuclide studies we don't do for all the tumors, but here it becomes a very important aspect of diagnosing. So traditionally we have been doing iodine 131, I-131 MIBG, and then later on it was I-123 labeled MIBG. This gives us a good diagnostic yield. But recently, the DOTATATE and the DOPA scans are being utilized because MIBG is not really available universally. And sometimes it is available after many months. So you can't really wait for the radionuclide to arrive and then to investigate and then do the things. Another important thing is bone scan, because bone scan will give you information about not just the bone but also bone marrow, because many patients have bone marrow metastasis in neuroblastoma. Now, PET CT is being done in certain centers, but the routine use of this FDG PET CT instead of MIBG or do an MIBG and PET CT is not advocated by the INRG task force. Right, some pictures, these are the 5 and 6-year-old boys. Here you can see this A is MIBG, tumor is not picked up, but advanced diagnostic studies. Now this was 18F FDG PET CT. Here it shows. So in FDG PET, as I was mentioning, it is not routinely utilized, but in a tumor which is shown on CT, for example, but it is not taken up by MIBG, you can do a FDG PET so that the tumor can be visible. Now this is in a 5-year-old boy. The first, this thing is MIBG. This is the MIBG. Again, this and this are two different. A and B are two different scans. The second one is by the DOTATATE with CT. So it is showing multiple metastases in the bone and the bone marrow. See here it is showing, as well as this is the bone marrow, the bone and the bone marrow, multiple all over the body. Right? So if you don't do these studies, you will not know. Now, supposing if you are not doing this, what will be the stage of the tumor? You just look at the primary. What will be the stage of the tumor? You'll probably label it at stage 2, max stage 3, depending on whether in. But this straight away goes to stage 4, the completely, and which will be probably falling into the category of high risk. If you are treating a high risk neuroblastoma with a low or intermediate risk protocol, what will be the outcome? You know the answer, right? This is the most important aspect, the histology. And here I'm talking of not just histology, accurate assessment by immunohistochemistry as well as molecular studies. Immunohistochemistry, we can go into the details when it started and all, but probably we'll skip that. But biopsy has to be done not just of the primary tumor. You can do it of the metastatic site also. Primary tumor or metastatic site, whichever is more easily amenable. But you need to do a bone marrow aspiration and biopsy both for suspected neuroblastoma. In immunohistochemistry, there are few markers. I'll just name them: B-catenin, CD56, chromogranin A, synaptophysin, NAC, that is neuron specific enolase, protein gene product, S100, and some few others which are expressed as DNA indexes, and MICN. Molecular studies is in our place it is MICN, which we were discussed in pathology or the histology. There are other studies which are not done in all the centers. So in the investigative modalities, there are other investigations which are recently being taken up by many centers. And I'm not talking of in our country, but worldwide. So for the whole body MRI, there was a prospective study which was done by Soliman et al. And he compared the whole body MRI to FDG PET CT, which we have seen in the detection of bone marrow metastasis. And he found that, meaning this study found that the whole body MRI is superior to FDG PET CT. We have other nucleotide studies like indium 111 pentarotride, but this is like as sensitive as MIBG, and this is not available at the moment. F18 metafluoro, that is MFBG PET CT, is one which is doing the rounds, and this has a higher lesion detection rate. It has identified 784 lesions versus 532 lesions which are detected by MIBG SPECT CT, MIBG I123 SPECT CT in one of the studies. So emphasizing here again, a complete metastatic workup is extremely crucial when you are talking of neuroblastoma. And is it different from other pediatric solid tumors? Yes, definitely different. Why? Because there are multiple metastatic sites which neuroblastoma metastasizes. It could metastasize to liver, to lymph nodes, to brain, to bone marrow, to bone, and to other areas, and maybe to all of these sites. Bone marrow metastasis is a very high percentage, and you may not even detect unless you do a complete metastatic workup. It's always a query. How do we differentiate Wilms tumor versus neuroblastoma? So a very short presentation I'll be doing. You know that the origin of both these tumors, though they may be in the neighboring locations, adrenal neuroblastoma versus a renal tumor, but still there are a lot of other differences. The age of presentation is a little different, wherein neuroblastomas can be diagnosed antenatally and they can present at birth, and the peak is less than 2 years. The peak in Wilms tumor is 2 to 5 years. The site of neuroblastoma could be anything. If it is adrenal gland, then it confuses with the Wilms tumor. Most of the Wilms tumors are unilateral, about 5 to 10% are bilateral. But here they are mostly unilateral. The bilateral rate is very low. It is 1 to 2%. So clinically, as mentioned in the exams, the Wilms tumor is smooth and well encapsulated. It displaces the structures and you can palpate it as a globular mass. But neuroblastoma is irregular, it is poorly marginated, and because it encases vessels, which you can't really palpate, but tumor wise, it does not feel the same as what the Wilms tumor feels. Wilms tumor rarely crosses the midline unless obviously it is a large tumor, but neuroblastoma often crosses the midline. Calcifications are rare in Wilms tumor, whereas they are quite common in neuroblastoma. Metastasis, I have already mentioned. Most of the metastasis in Wilms tumor is to the lungs and some to the liver, but here it can metastasize in many places. The syndromes with which it can be associated with are also different. Now, hypertension is more common in neuroblastoma due to catecholamine secretion and also because of encasement of vessels. Obviously, there are no tumor markers in Wilms tumor, but here there are tumor markers which are elevated in 90% of cases. Histological is absolutely no problem in differentiating, right? Prognosis is definitely much better in Wilms tumor as compared to neuroblastoma. And genetic markers are MYC amplification, ALK mutations, 1p11q LOH, that is loss of heterozygosity in neuroblastoma. Right. So we come to staging now. Now I'm not going to be giving you a detailed staging. At the end of the class, at the end of the lecture, I will share with you a PDF in which the detailed staging and the comparison of both is going to be given. Basic understanding is important. Just like in Wilms tumor, we had NWTS and then later COG, and we had PSYOP. Same way, we have COG and PSYOP in neuroblastoma also. So it's as per COG, it is INSS, International Neuroblastoma Staging System. That is a post-surgical staging where we have stage 1, stage 2, which is divided in 2, A and B, stage 3, stage 4, and stage 4S. Right? This we have been traditionally doing this for last so many years. My connection with neuroblastoma started 30 years ago. 1994, when I joined, neuroblastoma was given to me as the thesis topic by my teacher. And since then, like the first thesis that I did was more than 70 patients. It was the INSS staging. We never knew about INR-GSS because that was not there at that time. But now we are transgressing to INR-GSS, which is L1, L2, M, and MS, right? So this is a pre-treatment staging and it uses IDRF. What is IDRF? This is image-defined risk factors. L1 is localized tumor, L1, L2. M is metastasized and MS is like stage 4S. So when we talk of how much is of each category, stage 1, 2, 3, 4, you see this total here. This is stage 1, stage 2, total is 36%. And stage 3, stage 4, total is 58%. Stage 4S is just about 6%. So majority of the tumors fall in this stage 3 and stage 4. That is why neuroblastoma is different from all the tumors. Also, it is different because each and every tumor, even if it is stage 1, does not respond the same way because there could be molecular markers which could be different for the same tumor in the same stage. Right? So that is why the behavior, the biologic behavior is different. Right. So very important part is the risk grouping of neuroblastoma. Why do we do risk grouping? You know, triage, right, in trauma patients. So first and foremost is to identify the risk. Second is to assess how much is the risk. Third is to control the risk. And fourth is to review that what you are controlling is good enough or you need to modify that. So there are two risk groups for neuroblastoma. And outcomes as well as treatment, sorry, I should say treatment and then outcomes are dependent on the risk grouping. Traditionally, when I had started my neuroblastoma journey in 1994, we were not risk grouping. We never knew what was risk grouping. It was only a patient who had come in, diagnosis, neuroblastoma or not neuroblastoma, operate, give chemotherapy, and that's it. Therapy, of course, that time radiotherapy was there, though advanced radiotherapeutic options were not available, but radiotherapy was there, yes. So INSS. So INSS was developed way back, right? It was in 1988. That is, we divided the risk groups into two. You have already seen that, right? Favorable and unfavorable. And we still actually go through INSS and we still categorize this in favorable and unfavorable. But the INRG, which was which was formed in 2004, the investigators from many countries, cooperated from North America, COG, North America, Europe, that is the CIOPEN, Australia, New Zealand, Germany, Japan, China, formed this INRG task force. And they form this risk group. It is very low risk, intermediate risk, and high risk. Okay, very low risk group. We're not going to be discussing too much, but these are the group of tumors which are regressing on its own, like the ones which we just need to observe and they regress completely. Shimada classification, I'm sure you all know. INPC is the International Neuroblastoma Pathological Classification, which is in 2000, it was established in 1999 and later modified in 2003 as a very significant and biologically relevant classification. So what are the features of this classification? You need to know for, even now Shimada classification is being utilized in most of the centers in our country. So degree of neuroblast differentiation, you have understood that very well. You have answered also all correct. The presence or absence of Schwannian stromal development, that is the stroma rich or stroma poor, you are absolutely understood this also. The index of cellular proliferation, that is the mitosis karyorrhexis index, that is the MKI, the nodular pattern, and the age. These are the 5 parameters which you can very easily remember now in Shimada classification. So when we link it, maybe I skip this because it will become a little more complex for now. The age is linked to this. So this will be histopathological age-linked grading system, where the same parameters are used and we have added the age also in this, whether less than 18 months, 18 to 60 months, or more than 5 years. So for these grades of neuroblastic differentiation and for MKI also the age has been put in. So age has been correlated with these differentiating ones. If the age is less than 60 months, it has a better prognosis. If it is more than 60 months, it has a poorer prognosis. You will have to remember this because it is not possible. It is easy to understand, but it is difficult to remember. So you'll have to literally remember it. If there is a question in the exam about the histological indicators, then or Shimada classification, then this will be important for you. This slide will be important. Another thing which we have not covered earlier is what is MKI? You want to know? Yes, I have answered for you all. MKI is the main feature used for prognostic categorization in Shimada classification, and it can be determined more readily than the mitotic rate. Forget the mitotic rate for now. So assessment of MKI is based on a manual count. Any pathologist who's going through the slides goes through sufficient microscopic fields to include a minimum of 5,000 cells. A lot of work for the pathologist, right? So the count may be accomplished more or less strictly, but it is estimated rather than accurately calculated. It is difficult no, to calculate accurately the MKI or 5,000 cells. So for tumors which are highly mitotic, it is not difficult to give you the MKI, that is the mitosis karyorrhexis index. And the same, if it is where you hardly see any MKI, it is very easy to diagnose. The ones which are closer to the cutoff values between the intermediate and high or low and intermediate, or they are inconsistent from one field to another, a more careful evaluation of MKI is essential. So your pathologists play a very, 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 very important role If the pathologist has not done the job properly, your Shimada classification or risk grouping is going to be absolutely haywire. Why is this coming up again? Yeah. So MKI is classified into low, intermediate, or high. Which is good? Low is good. Less than 100 per 5,000 cells, or it is less than 2% overall. Intermediate is 100 to 200 cells per 5,000 cells, which is 2 to 4%. If it is more than 4%, if MKI is more than 4%, that is more than 200 cells in 5,000 cells, then it is high MKI. High MKI is not good. High MKI is correlated with amplification of MICAN also. MICAN is an independent the adverse prognostic factor. But when these both are together, it is a very, very aggressive tumor. We have already covered this stroma rich, stroma poor. So what is INRG now? We have mentioned about INRG. INRG is the International Neuroblastoma Risk Group. Okay. These many cooperative groups came together. They studied lot of patients, 8,800 patients. They analyzed 35 biomarkers and they prepared a list of combinations of prognostic factors so that they could assign the treatment. However, they found that many different neuroblastoma staging systems and risk classifiers were available worldwide because there are many groups, right? It is SIOP and SIOP or SIOP-10, we can say, for neuroblastoma. COG and SIOP is what we remember more commonly, but CCLG, that is from UK, the European Neuroblastoma Study Group, ENSG, the GPOS, the German Society of Pediatric Oncology and Hematology. So many groups were doing utilizing so many staging systems and risk classifiers. So INRG put in lot of efforts to develop approaches for staging and pre-treatment risk classification. And they provided an impetus, they provided a push to the COG to revise their own risk stratification systems. So, was the outcome good? Yes. The COG risk classifier was established in 2000 using the International Neuroblastoma Staging System. They were always using INSS, and that INSS was initially developed in 86 and then 88 onwards it was followed worldwide. And then a revised one was also published, 2021 COG Neuroblastoma Risk Classifier version 2. That uses the INRGSS, and it has been adopted to prospectively define COG clinical trial eligibility as well as treatment assignment. Great, isn't it? So this slide is a combination of clinical, pathologic, and genetic markers. Little too complex for now, but here I'll just quickly give you the gist of this slide. It is the stage of INRG, L1, L2, M, and MS, the age, the histologic category, the grade of differentiation, the MICAN, the 11Q aberration, the ploidy, and the risk group. Okay, so once this is done, then it is easy to assign the patient to a treatment protocol. So just remember now these 6 risk factors which are currently internationally recognized, right? Age, histology, grade, NMIC or MICAN, 11Q aberration, and DNA ploidy, right? You remember this? Easy, it's all very easy now, है ना? Chalo, let us see what treatment protocol we will utilize. Cyopen, I have already mentioned. Cyopen RNet is research network. Cyopen research network. Cyopen is the European Neuroblastoma Research Network, right? And the COG. They both provided the treatment options. The protocols are more or less similar. I'll very quickly run through, right? Traditionally, we know that we can utilize any of these or multiple of these categories for treatment of our patients with neuroblastoma. We can either just observe them, operate on them, give chemotherapy, give radiotherapy, and do bone marrow transplant. But the recent ones are immunotherapy, retinoid therapy, MIBG therapy, and targeted therapy. MIBG therapy is one of the forms of targeted therapy. So there are many more targeted therapy. But what, as surgeons, what we must remember and what we must assess is the timing and the type of surgical intervention. So as per COG, the low risk group, less than 6 months, only observation. Surgery for tumors which are increasing in size, not regressing, associated with development of symptoms, and for children with more than 6 months. And chemotherapy depends on, it can be given as per the histopathology. And we need to give a little low dose chemotherapy. For intermediate risk, chemotherapy first, 4 to 6 cycles, surgery with complete removal of tumor, radiation therapy, which is utilized based on the histopathology. It may not be required. No, I don't need to show you this. High risk. High risk is a little difficult. Treatment of high risk neuroblastoma is difficult. To give induction chemotherapy, which is high dose intensive multi-drug 4 to 6 cycles with autologous stem cell rescue. Surgery R0 resection is not needed, which means complete tumor excision is not required. Tumor can be removed as much safely as possible. And after which consolidation chemotherapy with high dose intensive chemotherapy, radiotherapy, bone marrow transplantation is to be done. And maintenance therapy is on retinoid therapy, that is 13-cis retinoic acid, immunotherapy, monoclonal antibody, targeted therapy with MIBG, and in combination, usually it is in combination with chemotherapy. So there are many more other targeted therapies which can be utilized. I've just given one of the targeted therapies over here. The Cyopen protocol, low risk is stage 1, select L2 and MS. Observation for less than 12 months with localized adrenal masses less than or equal to 5 centimeters without IDRFs. IDRFs play a very, very important role in treatment protocol or as per Cyopen protocol. And surgery is complete excision. Chemotherapy is reserved in cases where tumor requires, where it is unresectable, you have not removed a complete tumor, and so on and so forth. The intermediate risk Cyopen is stage L2 without NMIC amplification, where you give induction chemotherapy, then surgery, and then chemotherapy, and then as and when required, radiotherapy. The high risk neuroblastoma is stage M with an MIC amplification or unfavorable features. Induction chemotherapy with multi-agent regimens such as rapid Kojak, that is cisplatin, vincristine, carboplatin, etoposide, cyclophosphamide, reduce the tumor burden, operate. The aim of surgery is maximal safe removal of the primary tumor post-induction. Consolidation therapy is high dose therapy followed by autologous stem cell rescue to eradicate the residual disease. Radiotherapy is targeted to the primary tumor site, and maintenance therapy, that is anti-GD2 immunotherapy combined with 13-cis retinoic acid to eliminate the MRD, that is the minimal residual disease. So traditionally in the past, what we had been doing was relying on cytotoxic chemotherapy, and all patients of high risk were treated uniformly. Majority of the patients still relapse in spite of such high cytotoxic and myeloablative therapy. And when they relapsed, we had only very few regimens available, and those also did not work, which means that we actually lost that patient. And there was, if the patient survived, there was a high burden of late effects. But we are transitioning to a state of reliance on targeted therapies, precision oncology approaches, lesser patients with relapse, and multiple active regimens still available for relapse because we have not really utilized them to treat the high risk disease. Obviously, if we are using less of myeloablative therapy, there is a decreased burden of late effects in our growing population of survivors. So what is the outcome of treatment? Outcome is assessed under these 5 categories: complete response, partial response, minor response, progressive disease, and stable disease. This entire table or a chart, I will be giving it to you at the end of the lecture. So I don't need to go through in detail. You can easily go through later what is complete response, what is partial response, and so on and so forth. So so many studies are available. Some studies to show that complete surgical response, surgical resection improves the outcome in high-risk patients also, right? In localized neuroblastoma in children older than 18 months. So this study showed patients with complete resection had a better local progression-free survival, event-free survival, and overall survival than the other groups. But we must remember that if we are not able to achieve a complete resection is the goal. But if we are damaging some other organs or inadvertently performing nephrectomy, then complete resection is not acceptable. So for localized tumors with complete resection, it is about 85%, more than 85 to 90% tumor-free survival rate. For incomplete resection, it is 60 to 80%. For high risk, it is about 30 to 40%. And for 4S, it is 75 to 90%. Let me skip this. Refractory is different than recurrent neuroblastoma. Refractory neuroblastoma means that it is not amenable to treatment. So here we using much more myeloablative chemotherapy regimes. And for recurrent neuroblastoma, we use again myeloablative therapy. The late effects that we need to keep in mind and monitor when the child is growing up is hearing loss, problems with the bones and muscles like scoliosis, thyroid problems, growth and development, because radiotherapy as well as chemotherapy affects the growth and development of the child, fertility issues, neurological issues, second malignancies, including leukemia, and emotional or psychological issues. So this depends on the other frequency, and the extent of late effects depends on the primary tumor, what kind of therapy has been given, and so on and so forth. What is there in the future for us? It's all beyond the surgical domain, like immunotherapy, MIBG therapy, differentiating agents, angiogenesis inhibition, new targets like ALK inhibition, Aurora A kinase inhibition, TRK inhibition, CAR-T inhibition, tubulin binding agents, the epigenetic targeting, DNA methylation, histone modification, microRNA, microarray techniques like SNP, CNV, single nucleotide polymorphisms, mutations, and efflux proteins. So, judicious selection of therapy is extremely important here. Right. So, before I end today, I want to invite you all. This is very important invitation to join our Association of Pediatric Surgical Oncology, which is a section of IAPS. You can go to the website. The link is given over here, or I'll share the link of our Facebook, of Instagram, of our social media handles and the website. I'll share it with Dr. Alish and he can share it with all of you. Join us as associate members if you have not completed your postgraduate training or your MCH or DNB. And if you have, then you can join us as this. You can, there are a lot of advantages of being a member of this. And because you have stayed with me till the end and also participated actively, I am sharing a PDF with Dr. Alish, which he'll share with you, which has the details of what all I have covered today. And yes, I am open to any questions. Thank you very much. Oh, there is one more presentation. I'm sure you are all, oh. So moderators, can I quickly share another presentation, 10 minutes?
Ma'am, sure, ma'am, definitely.
Okay. This is important for us as surgeons, and that is why I thought I must share this. And that is the complications of treatment of neuroblastoma. Few things I can actually skip. Surgical complications. You have to prevent. You have to, if you can't prevent it, then you have to identify. And then unless you have identified, you can't manage, right? So you manage it properly, but only with accurate assessment of what you have actually what you have to manage, right? So how do we prevent or minimize complications? That is surgical risk factors we have to identify, or we have to identify the image defined risk factors. So this is a study done by a group in 1995. So there are two criteria. There is objective criteria and subjective criteria for surgical risk factors. Most of us utilized or have been utilizing a subjective criteria. What I feel may be a major complication, the other person or the other surgeon in another center may be, no, this is this is okay, this is okay, don't bother too much about it and don't worry, don't stress too much and all that. So objective criteria is the one which is much more authentic and reliable. Same way as IDRF. So IDRF was revised in 2011 and there were 4 distinct types. 2 categories were defined, 5 IDRFs or more, 5 IDRFs or more than 5 or equal to 5 IDRFs, right? So these are the 2 categories. If it is obvious, right, that if it is more than or equal to 5 IDRFs, then the complication rates you can expect as higher. So objective criteria. What are these objective criteria of risk factors that you need to identify to prevent the complication? Relationship between the tumor and adjacent vital structures, the vascular encasement, infiltration of intervertebral foramina, and the tumor crossing the midline. What subjective criteria we have been utilizing is tumor size. So some surgeons may feel even 10 centimeter tumor as, I can easily remove it. But some surgeons 5 centimeter also may feel that, oh, this is a large tumor. So subjective criteria, again, I'm emphasizing, should not be utilized only subjectively. You should combine objective and subjective criteria. And tumor fragility based on your investigations, your CT and MR. So additional objective criteria are, we've already discussed extension of the tumor and encasement. So cervical tumors extending into the thorax and nerve encasement, thoracic tumors where there is encasement of trachea or bronchi and involvement of lower mediastinum or abdominal extension, and abdominal tumors infiltrating into the renal pedicles or into the porta hepatis, or they are compromising the kidney or the ureter. Let's skip this. And IDRFs are of two types. They are extension IDRFs, infiltrative IDRF, neurologic IDRFs, and vascular IDRFs. Something similar we have already discussed in our previous things. So extension is, you understand, right? It is extending into the neighboring structures. So this is associated with prolonged surgery, increased chances of major blood loss, which means that you have to keep more blood ready. You could end up with organ loss, or you could accidentally ligate the vessels of neighboring organs. Infiltrative IDRFs, patients with these IDRFs were found to have more length of stay. LOS is length of stay in the hospital, 8 days versus 3.13 days. The neurologic RDRFs were associated with less complete surgical resections, huge difference in the percentage of complete resection, and vascular RDRFs were associated with a significant difference in rate of post-op complications, 26.7%. Right, so you need to know all the IDRFs very clearly. So identification. Now if surgical, we have talked about prevention, but prevention not possible. You have already landed up with a complication, they identify. Intraoperative complication and post-operative complication. Intraoperative would be major hemorrhage, which is more than 30% of the total blood volume, and unplanned nephrectomy. The kidney which was functioning, but you had to do a nephrectomy because of multiple reasons. Major vascular complications and organ injury or removal. So what is the total blood volume is weight of the child into 80, and major vascular complications are like damage to the aorta, superior mesenteric artery, celiac artery, IVC, depending on the location of the tumor, of course. Usually they can be dealt with repair, but sometimes they require prosthesis. If you are not trained enough for repairing or use of prosthesis, then please call a vascular surgeon. Now, post-operative complications, there is a classification of Clavin-Dindo, where there are 5 grades. Grade 1 is any deviation from the normal post-operative course, that is without the need of any further treatment, like surgical, endoscopic, or radiological. So you can just give some drugs and the patient would be all right. Grade 2 is requiring pharmacological treatment with drugs other than such allowed for grade 1, and blood transfusions or TPN to be given to these patients. Grade 3 is requiring surgical, endoscopic, or radiological intervention. 3A is intervention not under general anesthesia, but for children. This Clavin-Dindo is for overall, for adults as well as children. For children, generally we do most of the things in general anesthesia. Grade 4 is life-threatening complications, including CNS complications requiring ICU management. And grade 5 is death of the patient. You know the list of common post-operative complications. Chylous ascites is one of the most common complications for abdominal neuroblastoma. Others are general fever, electrolyte disturbance, diarrhea, paralytic ileus, gastroparesis, anemia, pneumonia, UTI, and second surgery, mortality. Long term, you could have complications such as kidney failure, vanishing kidney, means kidney failure even though you have done a good surgery. And kidney failure, I'm not talking of you have done a nephrectomy, right? Vanishing kidney, second surgery, prolonged diarrhea. So I will not go into the details except for this chylous lymphatic leak. So diet, which is medium chain triglyceride, TPN, somatostatin, and amino acid infusions usually are sufficient. Sometimes we have to do an exploratory laparotomy, ligation of lymphatic channel, peritoneal venous shunting, fibrin glue application, or transabdominal catheterization. So this is excision of the tumor. Majority of the chylus leaks are limiting within 2 weeks. Some of them only extend. I have seen few patients with the chylus leak, and somatostatin had to be given in most of the patients. Vascular injury, most importantly, do not panic. You have to anticipate this, and you have to be prepared for management. Now, this is one important slide for surgeons, right? When there is what we talk of no IDRF is for artery and vein. Vascular is artery as well as vein. Where there is contact with neuroblastoma, artery and vein, but it is less than 50%. The vein, the artery is not collapsed, but the vein may be collapsed, but it is flattened, but there is a visible lumen. IDRF means the artery or the vein is more than 50% encased. There may be total encasement also, right? The vein is completely flattened and there is no visible lumen. Okay, so this is what we were talking about, 5 or more RDRFs. This is complete excision of the tumor where the dissection of the aorta. So this is the tumor and the dissection begins from where the tumor is not encasing, just over the vertebral column. Can skip this. Vanishing kidney, I have seen this as well, is because of hypoperfusion of the kidney due to unrecognized vascular injury. And it is like a functional nephrectomy. So on table, everything is good. You don't see any the thing abnormal over there. The kidney also looks fine. But subsequently, when you do a sonography, you will see a shrunken kidney. If you do a DMSA study, you will not see any function in this kidney. This term is a very well-known complication, and you need to definitely prevent this. If you are aware, you can definitely prevent it. If minimal handling of the renal pedicle is required for this. Diarrhea, I can miss. Hypertension, I can miss. And that's it. Surgical outcome. See, this is an article which was published in 2024. All of these complication percentages have been given. Lymphatic leak, diarrhea, vascular injury, CBD injury, pancreas injury, hypertension, massive hemorrhage, so on and so forth. Right, so reported incidence of complications of neuroblastoma treatment, surgical care range from 20 to 50%, depending on the sample size, surgeon's experience, and the definition criteria for complications. In this study, which I have shown, the overall complication rate was 44.7%. How much complication do you want to have in your practice in future? Decide for yourself. You don't need to answer me, right? Thank you so much. Yes, I have taken only 10 minutes as promised. Right, so now we are open to questions.
Evangeline?
Yes, yes, Alish. I think Professor Saran has also joined us here. Sir needs no introduction.
I was there from the very beginning. I was there before she
Yes,
started.
yes, yes, sir. Sir, you wanted to make a few comments, sir.
One which I've said before also, Sushmita Bhatnagar, though younger than me, she has been my mentor for surgical oncology. She's the one who instigated me to get into
Thank you for saying.
surgical oncology. And I learned a lot from her, more than oncology, the dedication to her work and her honesty about things. I mean, that's fantastic. Very few quick comments. One is that both Wilms tumor and neuroblastoma can coexist in the same patient. One. Two, These are all rare things, but you should know.
Yeah, rare conditions, so I have not even touched upon actually.
Yeah. Now, why I'm just talking about WIMS and neuroblastoma because they're all there, and I'm too much into WIMS. I sleep with WIMS, I eat WIMS. That's the thing. One more thing that can happen is the intrarenal neuroblastoma. That's another thing that you should know, and there are ways to kind of differentiate between them. As regards the vanishing kidney that she talked about, that's something which is being talked about more often now. So it could be because of reduced blood flow, as she said, but it could be because of the intimal injury that may happen to these vessels when they are encased more than 180 degrees. She mentioned about less than 50 degrees, if you remember. But if they're more than 180 degrees or more, then the chances of intimal injuries while you're dissecting the tumor of these renal vessels is very, very possible. That also, and again, one more thing which we suggest don't regard, we should think about it as spasm of this renal vessel that may happen because we are doing such extensive dissection. So some people even administer papaverine intraoperatively, etc., etc. So that's something. One more thing which is there, I recently read from a very, very recent German article is that when there's a large tumor, I know when we had a discussion once on WhatsApp, they said, oh, we don't do nephrectomies. Sure, you've done enough neuroblastomas, you would done a nephrectomy of a kidney, which is pretty normal otherwise, working, functional, everything fine. So for such kidneys, the German group Warman and all that, Fuchs, Warman, Sushmita will know all them.
Steve Warman, yeah.
Yeah. So these guys now they talk about doing the tumor and the kidney removed together, bench surgery and auto transplantation of the kidney after they have separated the kidney from the rest of the neuroblastoma and put it back. And they recently reported 4 patients for that. After everything, the last comment is that although we surgeons talk about neuroblastoma, but we realize over the years it's becoming more and more a medical disease than surgery, and surgeons should not just go in to have some surgical fun in these abdomens because if you cannot remove more than 50% of the tumors in your first sitting or whatever you're doing, then you're really not adding much to the outcome of the patient. So if you have to give pre-op chemotherapy, whatever therapy, and reduce it, and then you're confident that you're going to be able to remove, say, about 90% of the tumor, sure, then you go in. And sure, the literature is full of laparoscopic excision of because it has to be removed piecemeal. But if you're not too confident about laparoscopy, just do your open surgeries and do them well. The time is too short. 1 hour is very short for neuroblastoma. Actually, the optimal time would be about 5 hours or so, I suppose. So the details of how to do the subadventitial dissections, etc., and how to save, especially celiac, mesenteric, and all those vessels. I mean, this probably can be discussed in some other session. Thank you very much for giving such a fantastic lecture, Sushmita. And I shouldn't be telling it publicly, but we have been sharing PPTs between the two of us, and I would want this PPT with me for my future lectures for the students. Thank you so much.
Thank you. Thank you so much. Yes. So any questions from the students? Are you muted, Evangeline?
And I just wanted to thank you, ma'am, again for taking so much time and effort in explaining this to us. Thank you so much. If anyone has any questions, please put it up on the chat box so that ma'am can answer it.
They can unmute as well.
It's late in the night. So
Yeah, yeah, that's what I thought. Okay, maybe questions will be less because the timings are such. Whole day they've been like working in the wards, and then in the night, first of all, to listen to the lecture and then ask questions over and above.
If I could
anytime.
barter my tumors, I would give the neuroblastoma to my colleague and take all whims from him. So neuroblastoma is a different ball game, poor outcomes, and you have to be really, really patient treating these patients.
Yeah, that's true. To our moderators, you can ask the students to connect later as well in case if they want to understand, or y'all also, in case if you all want to understand any particular aspect which you have not understood or missed, or it's not always possible to understand everything. And it's not possible for me to cover the entire neuroblastoma literature in 1.5 hours. It is not possible.
Yes.
I tried to make it as simple as possible. And there's still a lot of things missed out, but if you want, I can. And I have already shared a PDF with Alish. He'll share it with all the students.
Yes, ma'am. I forwarded in the group, ma'am.
Okay, already done that. Thank you. So if you need anything else, I'm always there.
Alish, share that with me as well on my.
Yes, sir. Yes, sir. I'll forward it to you, sir.
Thank you.
Thank you.
I'm always learning. Thank
Bye
you so
bye.
much.
Thank
Thank
you,
you, sir.
ma'am. Good night, ma'am.
Thank you.
Thank you, sir.